All right, guys, welcome back to the Atlas Hour. Really excited about today's guest. We have Dr. Michael Twyman. He's a medical doctor and MD, a board certified cardiologist. You guys were really excited about this one too, because I received going on 30 questions in a little poll that I put up just last night. So really excited to get to the questions that you guys asked. But yeah, welcome, Dr. Twyman. It's a privilege and an honor to have you.
Thank you for the opportunity.
Yeah, of course. So maybe we can start off with you just telling those few of our listeners who don't know who you are, because I feel like you've definitely gained a lot of popularity in the space.
Well, I'm a board certified cardiologist. I used to focus more on the invasive side of things, taking care of people who are having heart attacks, recards, really bad heart rhythms, taking care of people in the ICU and the cath lab. And while that was very rewarding, I always had this gnawing itch at there has to be a different way. Like, how do we get to these people earlier before they end up in the hospital this sick? What can we do differently? And if it was all about just aspirin, beta blockers, and statins, we would have stopped heart disease. So I kind of fell down the functional medicine rabbit hole for quite a while, looking at different advanced labs, and I still do that. And then later fell into the biohacking world and quantum medicine. So keep adding on little nuggets of things to help my patients really get to the root cause of their cardiovascular disease and live their optimal health spans.
Yeah, that's awesome. You and I have a pretty similar story in that regard, whereas I started down, like foot and ankle surgery, which I soon found out was 98% wound care and diabetic medicine. And I got into medicine because I was really excited about health and performance. And I thought I would be working with athletes in sports medicine. And turns out just, a bulk of my population was coming in when things were way too late, when this disease was way too advanced. And so I started focusing more of my focus on preventative. How could I teach people through coaching to eat better, to exercise, to prevent this? Because as you know, a lot of this is completely preventable and reversible even a lot of times, but people just won't want to do it. I'd have people come in where I tell them, hey, you have a little bit of loss of protective sensation in your distal digits. I think we need to really get this under control now. See them next year and I'm amputating that toe. I see them next year, I'm amputating half the foot. See them the next year and they're heading off to vascular surgery to get a BKA, and then they probably die within 5 years. It doesn't need to be this way. So it's pretty cool. We have a pretty similar story in that regard.
Right. And then I don't, people always, want me to kind of compare is traditional medicine bad? I'm like, no, it's a great tool when you need it. But, if you change your mindset, how about we make their, services less needed? That's really kind of what my mindset change was. So, I kind of thought about the Matrix. I was in the Matrix for quite a while. I unplugged from the Matrix. I still use those tools when I need to, but I also kind of future cast for people. I was like, if you don't take care of these things now, this is what you're going to look like in 5-10 years.
Absolutely. Yeah. I was just listening to your podcast with Dr. Saladino, and you said something about functional medicine. You said if functional medicine was the answer, then we wouldn't have any diseases. And I completely agree with that. But we do know that they have a lot of utility and validity, and we can take tools from them. We can take tools from Western medicine. So for some reason, we all get this dogmatic approach. We see it everywhere. Politics, religion, medicine's a big one, where you have allopathic or nothing. Everybody else is a quack and we can't listen to them. And then you have, the naturopathic side saying all allopathic medicine is, big pharma sold. And, it's nice to have individuals like yourself who can remove themselves from the dogma and say, hey, I think there's a little bit of utility in everything that people are saying. Let's meld them together and fix the patient from a holistic approach.
100%. Yeah. It's integrative medicine. I don't like using labels on myself often, but, integrative medicine is how I kind of think about it. I take the best from what I learned in my conventional training, the functional medicine, and then this quantum medicine, biohacking, just kind of melding them together and using what works for the patient. That's, most agreeable to that patient's goals.
Yeah, that's awesome. I love your approach. The more and more I look into you, I'm like, this guy's amazing. I love this. So I've been super excited about this conversation. And I thought maybe we could kick it off with almost laying a foundation for what is heart disease, more specifically ASCVD or atherosclerotic cardiovascular disease, because I think a lot of our conversation will be based on preventing that. Most people listening probably know that that's the leading killer of everybody, all genders, races around the world. So maybe you can give us just a little bit of a biochemistry 101 on what is ASCVD, or pathology rather.
Sure. So, ASCVD, as you just said, it's the number one killer of men and women, and it's something that should honestly be an orphan disease, and that's something I picked up from Dr. Piatia's newest book, is we know what causes it, but just because we know what causes it doesn't mean everybody's going to do the things they need to do to slow it down. So in the United States, still every 40 seconds, somebody's having a heart attack. So we have a lot of work to do. So I usually start off with, education to my patients. This isn't something where like your arteries are a sewer pipe and they just full of like sludge and now you have an event. It's something that's been going on for 10, 20 years maybe.
Right.
And you had a long time to intervene on it. So, I often say, you have 60,000 miles of blood vessels. That's a lot of blood vessels. But lining the blood vessels is a protective coating called the endothelial glycocalyx, and underlying that, the endothelium. It's basically, Teflon or a non-stick surface. If that protective gel coating gets damaged, then whatever's floating through the bloodstream, the white blood cells, the lipoproteins, which are basically the cargo ships for your cholesterol, and the platelets, then they start sticking to the artery wall. And once they get stuck there, especially the lipoproteins, they may get stuck in the artery wall, and that kicks off this entire inflammatory cascade, which then the plaques start building up. They're basically like little pimples on the walls of the artery. And your body can take care of it if it has enough time to kind of cool down the inflammation. The body will form a scar. But if the inflammation, oxidative stress continues to go on, then these plaques will continue to build up, and then potentially rupture. And then when they rupture, they spill all the contents of the bloodstream, the blood clots, and then you have a heart attack. But that's often kind of a surprise to somebody. They had zero symptoms, more than half the time before one of these plaques ruptures. So you have to go looking way upstream before they have their first symptom.
Yeah. And I think something that's cool and unique about you is you really focused on that first part of the process, which is the glycocalyx, which most of us never even probably heard about in a lot of our training. And then, we all know about the endothelium, but you're going, a step forward before that, even where you have this glycocalyx and then endothelium, and damage occurs to those areas. And it sounds like from what I've gathered from you, you focused a lot on keeping that integrity and healthy. Is that correct?
100% yes. The glycocalyx is a very delicate gel coating, approximately 100 layers of, the glycocalyx would be the thickness of a sheet of paper. It's very fragile. So high blood pressure, high blood sugars and insulin, infections, smoking. There's many, many things that can damage the gel coat. But if you get out of the body's way, often it can repair things. So it's more about withdrawing the things that are damaging the glycocalyx initially. And then there are different supplements, medications that might support the glycocalyx if it's injured.
Do you think it's possible to make it through life without some amount of injury, even if you're doing everything perfectly? Because I think there's a crowd now that tells people that it's okay to have elevated lipoproteins and everything, as long as all of these other risk factors are taken care of, which I do agree with. But my question has always been, is it possible to completely avoid all inflammation, to completely avoid all toxins that may damage it? And what's your take on that?
I don't think it's an all or none type of situation. I think it is kind of a gray zone. And, I often get in those kind of conversations, people are like, lipoproteins, good or bad. I always tell people like, there's no such thing as good cholesterol. There's just cholesterol. Your body needs it. But the more that I do this and the more the non-invasive testing gets more and more specific, is that I think if you go looking hard enough in most people after 40, 45, you're probably going to find something, some early signs of damage or actually advanced subclinical atherosclerosis that they had no idea that they had. And so in the conventional world, you tend to not to see a cardiologist until you're having chest pain, shortness of breath, exercise intolerance. And then they say, okay, well, let's do an EKG, maybe an echocardiogram to look at the heart function. And then we have you, get on a treadmill and you run around and then you kind of, see if you can pass it or not. If you pass the stress test, they're like, good job. If you fail the stress test, well, then you go to the cath lab and they do an angiogram and they figure out how much blockages you got and they fix it. But when they quote fix the blockage, they didn't really fix why you got the blockage. They just fixed one blockage in the 60,000 miles of blood vessels. And so you got to get to the root cause of what's damaging the glycocalyx. So to back it up a little bit is where, the novelty is that if you do different testing that looks at the endothelial health and the glycocalyx, and then look at vascular inflammation and look for soft plaque and then calcifications, you can find this stuff 10, 20 years before that person shows up into a traditional cardiology office.
Yeah, and I think that's where you kind of specialize. I mean, we can see, I see those things that you're wearing on your face right now, those very stylish glasses, and you do a lot of cool, unique stuff like that. That grounding, what are some of the kind of new, novel, unique things that you're doing that you feel like may help with promoting more cardiovascular health that haven't been mainstream or talked about?
Well, I mean, the free one is I always talk about circadian rhythm management. It's not always so sexy, but it's like the key. You have to have your rhythms in check. And it starts with the light environment that your body gets exposed to. The light is not only information to your body, but it also is energy. The sun has different wavelengths of light that your body's always tuning into. So the free biohack is don't miss a sunrise. That morning light in your eyes sets your circadian rhythm for the day. When certain other wavelengths come out, UVA, your blood pressure is going to be more optimized because it's going to help liberate nitric oxide. Then, UVB comes out later in the day. That's going to help your body make vitamin D. And there's a couple hundred different compounds that the body makes when UVB is hitting it. So I often tell people like vitamin D is a hormone. It is not a pill that you pop. Your body's supposed to be making certain things when the wavelengths of light hit you. So I always start with circadian biology first. And then, yes, the cool biohacking glasses. I mean, this is how I got into it is that, 2017, I'm taking a long flight over to Asia and I knew the jet lag was going to be really bad. And so I was like, how am I going to not die from this jet lag? And so I found some articles that talked about these glasses and just wore them on the plane. And I didn't understand the science at that time. And then my jet lag wasn't really that bad. I was like, that was like magic. How did that work? And then when I came back and researched, I'm like, oh, it's, your suprachiasmatic nucleus needs certain light signals to tell your body what time of day it is. I'm like, oh, that's interesting. And then I start going down the rabbit hole like, oh, it's really about mitochondrial function. Oh, your heart is like heavily dense in mitochondria, as is your brain. Therefore, those are kind of the two places that most people get their chronic diseases. And so if the mitochondria are failing, and your body can't make enough energy, you end up with a chronic disease. Oh, what do the mitochondria need? They need optimal light environment. They need to sleep well so that the mitochondria repair themselves. And then it just all start linking together. It's like, this is all a light story first, because everybody's going to want to go down the food story. And like food's important, but it's way down the list. So focus on the light stuff first. And so that's the free stuff I talk about with patients. Now, if they want to invest in photobiomodulation panels, cool, we'll talk about that. PBM panels are awesome. You can charge up your mitochondria and then go out there and do things that probably wouldn't be able to do without that extra energy. Heal up faster. So it's kind of like the Wolverine protocol. So you get injured, you heal faster. So that's the name of the game for HealthSpan is like, don't get injured for too long.
Yeah. So what are some actionable steps as far as, let's just say the sun first? I do want to talk about the light panels, but those who can't afford those panels or maybe don't want to invest in that yet, what can you do around the sun to optimize your health? What types of days should you expose yourself to? How long is sunscreen needed? That kind of stuff.
Sure. And it is going to be a little bit individualized to, your Fitzpatrick type. So, what is the likelihood that you're going to burn when you're out in the sun? So if you're, redhead, fair skin, you're not going to need as much time. You're very dark skin, dark, complexion, you're probably going to need a lot more time. So there's an app I usually, recommend people download. It's free. It's called DMinder Pro. And it just tells you when you go outside, if there's UVB light likely in your environment. So, where I'm at in St. Louis, there's 2 months out of the year where it doesn't matter how much skin is exposed to the sun. You're not making vitamin D because the sun doesn't rise high enough in the horizon. So I usually talk about just an optimal day and just trying to make it like Groundhog's Day, that you just repeat it over and over again. So I'm up before sunrise. I don't turn on a bunch of artificial lights, before sunrise. So either I'm wearing my glasses or I'm, using red lights at home. I go out at the sunrise. If people follow me on social media, it's usually my first picture of the day is the sunrise. It looks the same because it is the same. I see the same sunrise every day unless I'm traveling. So that first light in my eyes, the bright light from the sun is going to turn on the brain like, oh, it's daytime. And you start making cortisol and all your sex hormones. And then later, UVA light comes out. When UVA light comes out and it hits your skin, it liberates nitric oxide from the blood vessels. So that's going to help keep your blood pressure under control. And then later, depending where you're at on, the Earth's horizon, latitude-wise, will determine when UVB comes out. So this is when you're making your vitamin D. And how much time do you need? It really depends on your kind of solar callus, like how much, have you exposed your skin. If you have a very good solar callus, you might need a little bit more. But the DMinder Pro app is pretty good about that. You just kind of put in there like, hey, I burn really easily. And it's going to give you kind of like a recipe, like, hey, you should be out for 10 minutes today. And if you have just your chest, face, and back exposed, it's this much time. If you're just, if you're wearing a Speedo as a guy, then, you got 85% of your body exposed. You're making this much, vitamin D. Your body's basically a solar panel. So, if you don't expose to the sun, you're not going to be making the right hormones from it. So that's how I kind of always start off with people. Is like, you can use the sun. It's free. You just have to know how to use it. And that DMinder Pro app is a pretty good starting place for people. And then once you figure it out, you don't necessarily need to continue to use the app if you don't need to.
Right. So you said before, when you wake up, when the sun hasn't come up yet, that's when you're using the red light?
Well, yes, or just I'm using it more just to be able to read.
Right.
But I don't, because I often get that question is, when should you use your photobiomodulation panels? And it's pretty much any time is probably okay. But some people, if you use it too close to bed, it can be stimulating to them and it'll affect their
Hmm.
sleep. So everybody's kind of got to play around with it a little bit on their own. But from sun up to sundown is kind of the optimal window to use the red light panels,
Okay.
because you're just trying to mimic what the sun is doing. I sometimes joke that they're called supplements. You're just trying to augment what Mother Nature had.
Interesting. Okay. When I wake up at about 4, so it's usually at least 2 hours before the sun comes up. And I have been I just kind of turn on every light that I can because I thought that I was helping my circadian rhythm because I need to wake up at that 4. Was that misguided?
Yes, no. I mean, it really depends on what kind of lighting is getting turned on, because the majority of the LED lights, they're going to be set at like 5,500 Kelvin. They're set at the
Oh.
color temperature that is solar noon. So if you flip on a light, you
Mm.
bypass like the morning light where there's like a lower color temperature. So your brain kind of fast forwards. So it's not the greatest, but I'll think of that question, what about, schizoaffective disorder and bright light in the morning? Okay, I kind of understand that, but the sun's going to have more intensity than any of the happy lights that people use or goggles that they use. Another thing too is that like those things have usually limited wavelengths. You don't want to be over inundated with just quote blue light. So if you're going to use these happy lights, I usually recommend you have the red light panels on at the same time. So you're kind of trying to kind of mimic what Mother Nature would have given you.
Interesting. Okay. So would it be okay to, for example, I'll stay at my desk for about 12 hours in a day, and I do have my son. If I didn't, though, have the sun coming directly through the window most of the day, would it be okay to just have a panel beside you most of the day if, say, you're in a cubicle?
Yes, but also the one thing you mentioned is like if you're inside, you have to kind of crack the window, because if you're getting light through glass, the glass is going to filter out some of the right
Mhm.
wavelengths of light, the red and
Mm.
infrared. That's heat, that's keeping heat on the outside of the window. So more of the blue spectrum is going to be getting through the glass. So if you come to my
Mm.
office in St. Louis, it's all circadian friendly. It's, a corner office, all glass, but I still have red light panels and red light bulbs in my office to try to rebalance some of the light that's getting subtracted from the windows.
That's really cool. And then where do the glasses come in? Are you using those whenever you're exposed indoors to blue light?
Yes, I mean, anytime I'm in front of a computer screen, I always
Uh-huh.
have them on. Or if I go out in public and I'm not controlling the lighting situation, I basically call them like they're indoor sunglasses. These are not for
Okay.
outside, because you don't want to be blocking the wavelengths of light from the sun into your eyes. So that leads into the question, like, do I believe in sunglasses? For the majority of the time, no. I mean, there are some caveats. If you're driving and the sun's blasting you in the face and you just absolutely can't see, cool, wear them.
Sure.
If you're out on the water or skiing and you can't see, wear them. But the default should be the second you get somewhere where you can see, put them up on your head and let the full spectrum light get into your eyes.
I've always hated sunglasses for some reason. I just feel like I can't function appropriately. I feel like I lose detail and things, I don't know. I've never liked them.
And I
That's
was
really
addicted to
interesting.
them. And I was addicted to
Oh,
them
really?
4 or 5 years ago. I mean, like, say I go outside, on, on, on. And, because I would have the excuse like, oh, my eyes are tear, the light is so bright. And after a couple of
Yeah.
weeks of just getting some more morning light and just kind of easing into it, I never had to put them back on again.
That's cool. So yeah, that's all the light stuff, which like you said, free source, and you kind of dive into the red light that you can almost mimic things in a controlled environment. The grounding thing is something I'm really interested to talk to you about because seen you put out a lot of content about that. To be honest, I'll tell you, maybe 5, 10 years ago, like in my training when I saw it, I just thought immediately quackery. As more of that evidence based. That's BS. Now it's definitely interesting to me, and I think people like yourself would make very valid points. So I'd love to get into that a little bit.
Sure. And I have to give a lot of credit to Dr. Steven Sinatra. I mean, he's basically was the godfather of integrative cardiology. He figured out a lot of this stuff back in the 1980s and 1990s, but he had been exposed to some people who taught him about earthing and grounding. And you have to think about it is that every other animal in the world is always connected to the earth. We're the only ones that selectively decide to disconnect from the earth for long periods of time. And once we started living indoor lives and we had shoes that had rubber soles, we were rarely ever connected to the earth. And when you're connected to the earth with your hands or feet, the earth is negatively charged. It has more electrons than you do. And currents, I should say current, yeah, current will flow from, a high pool to a lower pool. So the earth is going to basically send you the electrons if you're connected to it. The electrons are utilized in your mitochondria. So we talk about food a lot. Well, food is mostly energy and information. your body's going to break those things down into electrons, and then you're going to shuttle those electrons through your mitochondria to make ATP, water, carbon dioxide, and infrared heat. But you can get electrons from earthing and grounding too. So you don't have to eat as much to make energy in your mitochondria. So you're going to have less reactive oxygen species, less oxidative stress, less rusting from the inside out when you're earthing and grounding. So from a cardiovascular standpoint, it helps the blood be more like red wine, less like ketchup. The red blood cells don't stick together as much because when the red blood cells are heavily negatively charged, they repel each other. It's anti-inflammatory, and it also just helps with energy balance. So, it's free. You just have to, think about doing it. So the default should be try to be barefoot outside when you can. And if you can't be barefoot, there are different companies that make, grounding shoes. So get a pair of grounding shoes or grounding sandals and just try to be connected more often.
And the part about the thickness of the blood is very interesting to me, and that was a thing that I picked up from you. I'd always question, what the heck is it about being on a plane that causes an increase in DVTs, deep vein thrombosis, for those listening, clots in your vessels? Because you're in this pressure controlled environment. I never really understood. I mean, people sit around all the time. Most people are sedentary. Going on a 4-hour sit for most people is not a big deal. But I was always wondering, why are we recommending compression socks? I deal with a lot of DVTs, and I never could figure it out. Then I heard you talk a little bit about that, so maybe you could elaborate.
I think it's a combination of things. Like when you're up in a plane, there's a couple things happening. One, you're disconnected from the earth. Two, you're in a mildly hypoxic environment. With hypoxia, your mitochondria are struggling to make energy as efficiently. You're getting cosmic radiation that your body's dealing with. That radiation is, causing inflammation in the system. And most people just chronically live dehydrated. When you're sitting up in a plane, you're basically like, a piece of meat in a microwave. Everybody's got their devices, they're blasting with Bluetooth, and, your body's just getting more intracellularly dehydrated during that process. And so with that kind of collapse of your exclusions of water on your blood vessels, the blood becomes stickier. So if the glycocalyx is negatively charged and your red blood cells are negatively charged, that's like a maglev train. They'll just slide on by each other. But if the glycocalyx is damaged and you have no negative charge, things start sticking like Velcro. And then that can lead to a venous thrombosis. So when I travel, I get the, morning sun. I try to get some earth and grounding in. I hydrate, probably I don't have more than normal, but I just hydrate, well. Maybe I take some ubiquinol or CoQ10 to try to quench some of the oxidative stress. I'm wearing my blue blockers on the plane because that's just all junk light in the plane. And I try to get up and move around on the plane. So, and that's kind of my thing. But like if you're at even higher risk, then yes, the compression stockings, potentially, aspirin, potentially even, one of the low molecular weight heparins, something that you really prevent your blood from sticking a lot when you're flying long distances might be useful. But talk to your doctors about that before biohacking that on yourself.
Yeah, no medical advice here.
Right.
And when I've experienced more like the phenomenon, I guess, well, you've explained it very well in, concrete evidence, which I think is the coolest. But grounding, going to the beach, like I went off to a trip earlier this year and went in the ocean, and there's almost a euphoria that you feel that's like, it was almost, and like I felt almost high on something, I'm like, nothing has felt this good in so long. I've been just grinding away for years and now running into the ocean, which is so simple. I'm just sitting there like, this is amazing. And seems like there must be something to it.
I think there definitely is. A lot of people just want to say it's like the relaxation response, like, oh, I don't have to do my, 9 to 5. And then, I'm just in different environments. Like, no, that's what you're supposed to be. You're supposed to be connected to the earth. You're supposed to be getting full, spectrum sunlight on you. And when you go to the beach, yes, you are basically, collecting a lot of electrons and you're powering up your systems at maximal levels for the most part. And so, often will notice is that when you go to the beach, you're generally not that hungry because you're soaking up electrons through other sources. But the sun does make you make, POMC. There's a long word that, as a compound that's made through your eyes, but part of it will ultimately get broken down into beta endorphins. And so it literally is hitting parts of your brain that make you feel good. You become addicted to the sun in a good way. Yeah. There's no negative feedback loop and there's no true withdrawal, even though I swear that there is something where I call it acute sun withdrawal. So like if you go to Mexico in the wintertime and you go back to your cold environment up north, you do feel kind of like, I can't believe it. I'm disconnected and you feel off for a while. So that's where you have the red light panels sometimes can be a supplement to get you through the winter.
No, I think that you're definitely onto something there, because we went in November and then we came back here to Michigan where it was just a terrible winter, and almost immediately felt my wife, she felt really depressed, and we're like, Jesus, I mean, we're moving to Texas here in a few weeks because we can't do these winters anymore. We need to be able to experience, walks outside for, hopefully most of the year. Because when you go 6 months without being able to walk outside, you feel it, and I never thought that I suffered from seasonal affective disorder, but I also grew up in California and then Arizona. So I'm like, yeah, no, this is the first time I've been exposed to it. It's pretty rough.
Yeah. And back to your point of like not being able to walk in the winter, I just say that, there's no such thing as it's too cold. It's just you're not
Right.
wearing the right clothing. And when you
Sure.
also get into like cold thermogenesis or direct cold exposure, you learn how to embrace the cold. It's the lack of
Yes.
light that starts getting people.
Exactly right. Yeah, because when we go out, we would be fully bundled up. We didn't have any sun. I don't mind walking in the cold, but when the only thing's exposed is right here, I'm like, I'm really missing out on the sunlight,
Right.
and we could feel it. And, we got to, even on the warm or the cold days that were sunny, it feels so much better.
For
And
sure.
that brings up a point too. What difference does the cloud make? The cloud coverage. Is there a significant decline in what you're getting?
There's a decline, but you still get benefit. Yeah, I get that question.
Yeah.
Like, what if it's raining outside? Doesn't matter. Like, you're still getting certain wavelengths of light that bounce off other surfaces and get into your eye. So, yeah, when there's a lot of cloud cover, it's going to block a lot of the UV wavelengths. So you're not going to get as good of a tan, or you're not going to make as much vitamin D that day. But it's kind of on average, are you making the right hormones?
Okay. And so, yeah, let's talk about vitamin D, because I want to kind of pivot into supplementation. And vitamin D, one thing you said was you don't need to necessarily supplement with it. You should be making it. So are you against vitamin D supplementation, or do you recommend it ever to your patients?
Two-part question. I mean, like, yes, do I recommend it on narrow,
Hmm.
like, you have osteopenia, you have fractures. Okay, like we understand, like, we got to kind of like front load you on things. But the default answer really is no, because I use it as a marker of like how much proper sun exposure you're getting. If you're taking it by pill, it works in your body differently than if your body made it from sunlight. When sunlight strikes your skin, it sulfates the cholesterol in your skin, and then that sulfated cholesterol goes to your liver, then to your kidney, and then it's the active form of vitamin D. So it is always true that if you have a low serum vitamin D level, it's associated with increased all-cause mortality, autoimmune conditions, cancer. But what is not as clear is that if you pop pills and make your blood level X, that you're necessarily reducing all those events. It's just a marker that bad things are going to happen because you have low vitamin D levels. Your immune system doesn't work as well. When your immune system doesn't work as well, you end up with autoimmune conditions. And that's like a stop or two before cancers, when your immune system can't surveil and clear cancer cells. So, the blood vessels are kind of sometimes innocent bystander. The inflammation damages the glycocalyx, and vascular processes also continue to kick off even more. So I use it just more as a surrogate. Like I said, what is your proper sun exposure? But I often get too, like, well, people are like, I'm really tan, I'm outside all the time. Okay, well, what are you doing when you're inside? If you're spending 8 hours a day staring at a screen the rest of the time, that blue light from your screens is going to mess with the vitamin A on the opsins in your eyes. The vitamin A is yoked to vitamin D. So if you're getting a ton of blue light in your eyes without protection, that vitamin A that gets liberated from the melanopsin receptors is going to drag down your vitamin D. So, you have to protect your eyes as well. Your body has to be hydrated. So if you're not hydrated, you're not making this as well. So it's complicated, but I always start with like, I will look at the levels, but it's not, magical that, somebody pops a pill and the blood level's all in 60, that they're all solved. I mean, they have to get everything else right too.
Right. Is there a level in the blood that's your target? Like, do you have a goal for levels?
I generally shoot for around 60, but that's 60
Okay.
without supplementation.
Yeah, interesting. So part of the problem that I run into a lot, and maybe you do too, is with patients, like we can tell them to do all the activity and the lifestyle stuff, but will they do it is hard. So that's where I usually will just default to, I give supplementation because they're at like 20, and I want them to be above 50, ideally, usually. And so I give them supplementation, but I do tell them get sunlight, and I try to express that. Do you run into that too? Or are your clients a little bit more dedicated, since if they found you, they're a little, down that path already?
Some of them might be a little bit further down the path, and they've already heard me or other doctors talking about this. So they're already coming in with that knowledge. But
Right.
no, I'm not necessarily opposed on the face of like say, hey, we're going to get you started while we're teaching you this. But I'm going to tell you, like, it doesn't always matter what I do, but like, I don't take vitamin D. Yeah. If I've had, major infection or something like that, cold, maybe I'll kind of burst it myself for a couple of days, but then back to, the Mother Nature way of doing things. So I won't be a hypocrite and say I never take vitamin D, but like it's not the default.
Right. Yeah. And then outside of just bone health, which you mentioned, and immune system, what are some symptoms that people might feel if they're suffering from low vitamin D?
They may not necessarily have a lot of symptoms per se, but low vitamin D is going to be associated with, more depression. It's going to be more with, my world, like if people are on certain lipid lowering therapies, they'll get more muscle symptoms at times. Lower vitamin D is associated with higher blood pressure. So it's all encompassing. It's just a marker that, like, if you have low vitamin D, your body hasn't been plugged into nature enough, essentially is the way I think about it. You're probably running low. You're like a half charged battery. You're not going to be working at peak capacity.
Yeah, it's funny because I'll try to express that to people. We get so many people in who are convinced that they have issues with testosterone. Testosterone is just sexy because it's, illegal for whatever reason. But I'm like, you do realize this vitamin D is also a hormone. It's not, I know it has the word vitamin in it, but this is a hormone too. And I have guys who have totally normal testosterone levels with a lot of the similar symptoms to low testosterone. They think that's the cause, but I'm like, your vitamin D is, single digits. And I really, truly feel that if we can get this up, you're probably going to be resolved of a lot of those issues you think is related to testosterone.
Correct. Yeah. And that's definitely probably a couple hour conversation is all about the sex hormones. But the one way to think about it is, like, if you have low sex hormones, what else is going on in your environment? If you're not sleeping well, if you're not managing your stress, if you're not getting the proper fats, your body's like, we got to keep the heart and brain alive. Like, we do not care about reproduction right now. So, fix the basics first.
Yeah, absolutely. What other supplements are on your horizon? Like, what are you looking at using? What are some new trendy things that may help in that initial step of promoting the integrity of the arterial lining with the glycocalyx, the endothelium? Anything in particular?
So, like I said, I always kind of look at the root causes of cardiovascular disease, and it pretty much always starts with supporting the endothelial glycocalyx and the underlying endothelium. So, nitric oxide is the name of the game in the cardiovascular system. So, I know the science nerds out there are going to be like, what about iNOS and nNOS? Okay, cool. We're not talking about that. We're talking about endothelial nitric oxide. So, the arteries. So, higher levels of nitric oxide in the arteries is going to promote arterial dilation. So, that's going to keep blood pressure down, shear stress down. And higher levels of nitric oxide is going to act as a repelling force so that the white blood cells, the lipoproteins, platelets don't stick to the arteries to begin with. So if you have low nitric oxide, bad things are probably going to go on. This is the whole side story about, Viagra. How do those type of medicines work? They're keeping nitric oxide around longer so that you can maintain blood flow into the penis and have or maintain an erection. So nitric oxide, extremely important. But there's many things that break it. Try to remove those things if you can. So some of the less obvious ones are mouthwash. Mouthwash can destroy the oral microbiome, and then any of the nitrates that you're eating in your diet aren't going to be able to be converted because you need the nitrate reducing bacteria in your saliva to make that conversion. Humans don't have the bacteria to naturally make a nitrate into a nitrite. And then you need stomach acid. You need stomach acid to digest your proteins. You need stomach acid to make certain enzymes, which are, different types of proteins. So if you're on proton pump inhibitors or popping Tums all day long and have no stomach acid, you're not going to have this reaction happen as well. And so you're going to need more support. Fortunately, there's a couple companies out there that make compounds that help support nitric oxide. And there's a couple companies that are making things that support the glycocalyx. And then depending on the person's, unique biochemistry, potentially their budget, you decide, okay, this is the right cocktail for you.
Is there anything that you think would benefit most people just broadly? Like, I know you mentioned ubiquinol earlier. Are there things like that most people could probably benefit from with low risk?
Yes, no, but I hesitate to just say everybody should be taking these 3 supplements because, we weren't designed to be born needing those things. Like, there's times, places where you're going to be deficient, replace the deficiencies. And the sicker you are, you might need more, at least short term, while you figure out why they're so deficient. But I hesitate to say that everybody should be taking fish oil, for example, or magnesium. They're useful at times, but not for everybody at all times.
Yeah. See, and this is why I wanted to get you on. So all you listening, this is a board certified MD cardiologist right now. I'm trying to twist his arm to even get him to give a recommendation for fish oil. And so even on the naturopathic side, you're not willing to really push a lot of supplements. I think that's really cool. And it sounds like you're kind of in the belief that most of what we need is probably just outside in nature, how we would have otherwise lived, not given the societal structure that we're in.
Right. And I always kind of break it down into, the 4 pillars I've talked about of health. It's exercise and nutrition, but it's stress management, sleep. Like if you're not sleeping well enough, almost anything else we talk about isn't going to matter that much. Like you have to sleep well so that your mitochondria repair. You almost have to, trick yourself into thinking like your day does not end when you go to sleep. Your day begins when you go to sleep. You lay your head down on the pillow, you're charging up your battery, and then you wake up the next day and you dissipate it. So if you're not sleeping well, focus on that first, and then everything else will make it a lot easier to get it to work well for you.
Yeah, that's awesome. Well, you mentioned Viagra, which is a phosphodiesterase 5 inhibitor. There's also Cialis, which has a much longer half-life, or tadalafil. A lot of people in the kind of biohacking realm will utilize those daily for potentially improvements in the endothelial lining through the nitric oxide pathway that you discussed. There's some literature on it helping to promote testosterone production and androgen receptor sensitivity. What are your thoughts on those medications being used like that instead of for their intended use for just erectile support?
Not necessarily on the face opposed to them, but I always will talk about that. If you're taking those medicines and you're getting a response, that's not a bad thing. But is there a problem with your body's ability to make nitric oxide to begin with? Because that's all it's going to do is keep nitric oxide around longer. So those type of medicines, and up to half the people that take them, they don't work. People don't get better erections because they're not making nitric oxide to begin with. So you have to fix the glycocalyx first, and then those medicines tend to work better. Because if you have nitric oxide around, yes, you're going to have a better pump in the gym. You're probably going to have better exercise performance. So not opposed to those things, but make sure that you're doing all the kind of free things first is to support nitric oxide.
Yeah, and the mouthwash thing is interesting. It's kind of esoteric. Not a lot of people know about that. I brought it up with one of my best friends from undergrad, became a dentist, and I showed him some literature, and he was really impressed on it. There's some literature of, like, I'm sure you've read, there's in the ICU using chlorhexidine, which is a very common practice for patients. Will swab their mouth with chlorhexidine to what we thought lower bacterial burden, et cetera, and they had worse outcomes. So maybe you could touch on the mouthwash thing a little bit.
Yeah, those are something I learned from Dr. Nathan Bryan, who's a PhD who has done a lot of the seminal research on nitric oxide production and has multiple patents for different products that support nitric oxide. And that's what they had, seen as well, as they were testing saliva in patients and looking at different bacteria and figuring out okay, which bacteria are the ones that tend to help promote nitric oxide production. And then when people were using very astringent mouthwashes, the good bacteria, they were killed as well. So a lot of people in the functional medicine world understand the gut microbiome, but the oral microbiome is also important. That's your first interface with the world. So there's a huge oral systemic connection. So if you have periodontal disease or other things going in your mouth, that kicks off all this inflammation that the arteries are going to be transmitting. And that's kind of the process where some of this subclinical atherosclerosis kicks off, is that you have unhealthy mouth. So that's one of my questions. I ask people hey, how often do you see your dentist? And is there anything going on with your mouth? Because that directly impacts what's going on with your cardiovascular system. But it always kind of blows people's minds. I thought mouthwash was good for me. Well, if your dentist has you to prescribe plain, hey, I want you to do this for 2 weeks, 4 weeks because you have this infection or whatever, I'm not going to be opposed to that. It's the people using it every day for years on end, and they're having high blood pressure or stiff arteries on some of this testing. And they're like, well, I don't really want to take medicines for blood pressure. Okay, well, why don't you withdraw the things that are potentially affecting it? So there are these test strips, and they're a move in the right direction for some people, but there's different companies that make these test strips that can test your oral nitric oxide levels. They kind of like litmus paper, put saliva on them, and turn bright red. You're making good oral nitric oxide. But in some people, the levels are always low. Those people are a little bit more complicated because you don't know, do they have the capacity to ever get high? If they were high and they go low, then they did something that affected the oral microbiome. And so either put more nitrates in or withdraw the things that are breaking the nitrate producing bacteria.
Interesting. Do you have an oral hygiene regimen for people that you say to use in replace of, I've heard of coconut oil, things like that? Do you utilize any things like that, or a little more natural that may not impact nitric oxide to that extent?
It's one of those things where I tell people it's test, don't guess. I don't know all the products out there that people are going to be trying. And so some of them may be just totally fine. The way you would know is that, if you're doing certain testing, that your blood pressure is staying normal. If you're doing some non-invasive testing, your arterial elasticity staying normal. If you have the test strips, you're still getting the bright red levels, okay, then whatever mouthwash or oral hygiene product you're using, that's working for you. But if your levels are white as my shirt, then there's still something that's probably off. And even though it's organic and healthy, maybe your bacteria in your mouth don't like that.
Sure. And I like your whole philosophy of test, don't guess. So for those who are, we kind of talked earlier about what you would do if you walk into a cardiologist at age 60, but a lot of our listeners are probably closer to my age, mid 30s to 40s. What can individuals like myself who are starting to be concerned with this, or at least want to do as much preventative stuff, what kind of tests can they do from lab works to more diagnostic tests?
Sure. And I do kind of break it down into two buckets. There's the biophysical. So what are the arteries actually doing? And then there's the biochemical. And so the biophysical is actually more important in my mind. It's like, certain people have high lipids their entire life and they never develop atherosclerosis. And there's people with low lipids that still have a heart attack. Half the people who have heart attacks have, quote, normal cholesterol. So I was trained that, there's maybe up to 400 different risk factors that damages the arteries that sets off this plaque cascade. So I always want to test the arteries first. What are your arteries doing with information of what's floating through it? So kind of starting at the beginning is like, there are no direct tests at this time that look at the glycocalyx. You have to kind of look at some tests that are affecting the endothelium, the lining under it. And so I'll kind of walk you through what, if a patient who's like 45 years old come to my office, their dad had a heart attack at 60 and they're like, I don't want to go down that pathway. Cool. This is what I would do for them. They would come into my office. I would do one of the oral nitric oxide test strips and see where they're at. If, they're white, okay, I just note it, but that's not the be all end all that, hey, something bad's happening. Then, I have a pulse wave velocity device. It's a company, Max Pulse makes it. Looks like a finger probe. Instead of measuring the oxygen in your finger, it's measuring the elasticity of the arteries. So as the blood's going into the arteries are expanding and contracting. If you have healthy arteries, it should be like an accordion. It expands and snaps back very quickly. If you have sick arteries, it's going to be like a little lead pipe. And so we can kind of grade how stiff the arteries are. Then we assess your blood pressure. And not only do we check your blood pressure in your brachial arteries, the blood pressure in your biceps, and we check it on both sides, which you should always recommend somebody do the first time they see you, is because some people have a differential in their blood pressure. One arm will be lower than the other. Sometimes that's due to a blockage in their subclavian artery. Sometimes it's a nervous system, issue where the nerve is impinged and the artery is getting constricted. But you want to take the arm that has the higher blood pressure. But that blood pressure isn't as important as knowing what your central aortic blood pressure is. So we have a device called the Accor device, which non-invasively measures your blood pressure as it's coming out of your heart. And that's the blood pressure that your heart arteries, brain, and your kidneys all sense. So they might have to hit a pause for here 1 second. All right, so we'll pick up from the Accor central blood pressures. So
Sure.
the Accor device measures your central aortic blood pressure. That's the blood pressure that your heart arteries, your brain arteries, your kidney arteries all sense. And when I was an invasive cardiologist, we used to put a pigtail catheter through your radial artery, your femoral artery, and measure it. Well, people don't want me to put needles in the office, so this device measures it non-invasively. It does it somewhat similar to the pulse wave velocity, like how elastic the arteries kind of calculates this number. But that's the number that you want to see, 120/80 millimeters of mercury, because your blood pressure is a surrogate, essentially, how healthy the arteries are. Often joke that high blood pressure is not a disease. There's just something wrong with the way the arteries are relaxing, or body's not able to make nitric oxide, or there's a lot of inflammation, and the bodies are just responding in kind with that. So you got to get to the root cause of what's causing the high blood pressure. We also have a device called the EndoPAT, which is kind of like a stress test for the endothelium. So it's a 15-minute non-invasive test that looks at how much your arteries will release nitric oxide when there's a stressor on them. And it'll give you a number known as the reactive hyperemia index. So ideally, your arteries should at least double in size when there's a stressor. Optimally, the arteries will triple or quadruple in size. But if it's less than 1.68 on this RHI, then you have endothelial dysfunction. And that is the first line of defense of your arteries. It used to be thought that way, but it's actually the glycocalyx. But there's not a number that I can measure on the glycocalyx. So I usually will still default to say, like, if your endothelium is impaired, that's the first sign that something's going wrong with your arteries. And this can happen in your teenage or 20s. And so this is where you want to start intervening sooner. But if you have endothelial dysfunction, the process is going to keep building up. You're going to develop inflammation in your arteries ultimately. And that can get picked up with the carotid intermedial thickness scan or ultrasound of your artery on the side of your neck. You can measure the layer of the artery under the endothelium. The thicker that layer is, the more inflammation in the artery. The more inflammation in the artery, the more likely you're going to continue to build up plaque. And that's the test that gives you your, quote, vascular age. So as Dr. Thomas Sydenham back in the 1600s had a saying, a man is as old as his arteries. So if you're a 40-year-old man and your arteries are 60 years old, you're essentially 60 years old. And you have to figure out why are your arteries aging faster than you are. And so the next question always comes like, is it reversible? Yes, but first you have to find it, figure out what's causing that damage, and then help the body back that up. But usually within 6 to 12 months, you'll start seeing things back up if you withdraw the offending agents. So that's why I start with almost everybody, under the age of 40. It was just like, hey, how healthy are the arteries right now? After the age of 40, it sort of depends on kind of family history and potentially genetics. Is a CT coronary calcium scan is kind of a default, but it's not a perfect test. You're still going to miss 10-15% of people. But for those that don't know it, the CT coronary calcium scan or the calcium scan, it's about $100 at most places. And it's kind of like a mammogram for the heart. It's looking for calcium in the walls of your arteries. Calcium is supposed to be in your bones. It's not supposed to be in your artery walls. So the higher the calcium, the more plaque that you have in the arteries. So at the age of 40, your score should be 0. But that does not mean that you have necessarily completely healthy arteries. You could have a lot of solid arteries. You could have endothelial dysfunction. It just means that you're not really late to the game. If you have a positive calcium score of 40, you're like super high risk, 5-alarm fire. What's going on with this person? The converse is like if you're an 80-year-old and your calcium score is 0, then whatever you've been doing is working for you. And so maybe you don't want to break too much with that person. So that's why the calcium score test is a good test, but not a perfect test. And there's new tests that are coming online that are looking at, the plaque volume, like how much plaque do you have in the entire system, and what is that plaque? Is it soft plaque? Is it hard plaque? Because the events tend to track with the soft plaque. But that test requires more radiation, it requires IV contrast, and it's more cost expensive than just doing a calcium score. So it's not for everybody, but for the right population, that's kind of the gold standard, is doing these kind of CT coronary angiograms with the AI overlay for them.
Yeah, I kind of have a love-hate relationship with the calcium score because so many younger individuals will use it as oh, I'm fine. And I'm like, no, I wish we really explained to them what it meant, because like you said, you should have one. And just because you don't doesn't mean that you can continue to live a lifestyle that's not conducive to proper cardiovascular health. It's, I think like Peter Attia mentioned, I love the analogy of that would be the equivalent of continuing to smoke until we saw lungs in your tumors. You don't want to do that.
Yeah, you don't want to wait until like the plaque is so evident. You're like, oh, we should probably stop this now. And that's the concern I get sometimes is, with the statins are bad, statins are, should be in the water kind of debate, is that it's never that straightforward. It's, what is that person in front of you doing? Like if they have healthy endothelium, no inflammation in the artery, and they have, quote, high ApoB, well, maybe there's another reason to have high ApoB and work on that. But if they have significant plaque in their arteries, then statins might be the right tool for that person. But you got to describe like, okay, how do statins work? What are the potential side effects? There's different blood tests you can use from companies that say like, oh, this probably will work better for this person than using ezetimibe or using a PCSK9 inhibitor. Like tailor the tool to the person's condition.
That's interesting. So those are the more diagnostic imaging and stuff. How about lab work? Because there's a lot of direct consumer lab now. A lot of people there's less barrier for entry. So is there labs that younger guys or younger people in general should be looking at?
Yes, but it is somewhat complicated because like the list of labs on my mind always changes, and it sort of depends on what labs you have access to. But if you want to kind of break it down again into kind of 3 buckets, you want to look at certain labs are going to look at oxidative stress and inflammation, because, if your arteries are on fire, you're much more likely to develop the plaque later on. So what are those labs? Well, high sensitivity CRP, if you have access to it, LPPLA2 and myeloperoxidase would be good vascular specific inflammatory markers. Oxidative stress markers going to be oxidized LDL or oxidized phospholipid on ApoB, and then a urine test called F2 erythropoietins, and it's a urine test. If you have high F2 erythropoietins over your creatinine, then you have, your body's more likely rusting from the inside out. And then we'll look at markers of endothelial dysfunction. Most of them are going to be biophysical that we just mentioned, but some of the biochemical ones that I kind of point towards, you're probably likely to have lower nitric oxide levels are going to be, if you have high levels of asymmetric dimethylarginine, which is ADMA, or SDMA, symmetric dimethylarginine. If you have high homocysteine, that often drives high ADMA. If you have high uric acid, that lowers endothelial nitric oxide synthase. Those are kind of the starting points. But another one that is a urine test is your urine microalbumin and creatinine. For people who are diabetic or have high blood pressure, that's what we would use is, if the cutoff is like 30. If they were 30, they're leaking a lot of protein into the urine, which is a large compound that shouldn't be in your urine. So the more protein you leak in your urine, you can think of it as endothelial dysfunction for your kidneys. Well, if you have endothelial dysfunction in your kidneys, you likely have it elsewhere. So I will use that test for kind of testing your endothelial health. And then the third bucket is going to be more the lipoproteins. And if you only can check one, I would just check ApoB, apolipoprotein B. If you can check more things, then yes, check the full complement of particles, the LDL particles, the HDL particles, the VLDL particles. I should get that, you should always have LPLA checked at least once in your life, because upwards to maybe 20% of people will have high levels of LPA. And that's the number one genetically inherited lipoprotein that increases the risk of early cardiovascular disease. So you want to get it tested. If you're low, you always have low levels of that. So those are kind of the three buckets I tend to think of. And then there's a lot more nuanced things. Yes, I'm going to be checking thyroid levels and markers of insulin resistance and sexual hormones. But if you're going to carry it down to the arteries, those are the three buckets.
Awesome. Yeah, I like that you mentioned uric acid too. I think that's one that doesn't get enough attention. I spoke to a bunch of podiatrists and general medicine docs recently and was talking about, when you're seeing gout, it's kind of similar to the calcium score. If you're seeing calcium, things have gone too far. So if you're seeing a gout attack, there's probably a lot of damage that has been preceding this. And we used to think of uric acid equals gout, and we didn't take into account all of the other associations that there are, like elevated blood pressure, insulin resistance, metabolic syndrome. And, I put it out there, is the uric acid the chicken or the egg? And I kind of do believe at this point it's more of the chicken. I think that high fructose diets, et cetera, lead to this uric acid endothelial dysfunction, which causes a cascade of other things. And gout is though it's painful and acutely, right in your face, there's a lot going on under the hood that we don't realize.
Right. And it's the straightforward blood test. So.
Yeah. So I think at this point, maybe we could dive into some of the Q&A, because there's a lot of medication questions in there that I think will dovetail really nicely on what you just alluded to there with the, the statin therapy and everything. So let me see if I can figure out how to pull these up. Yeah. So and maybe we'll talk about right off the bat. Somebody asked, are cholesterol numbers as much of a concern as we once believed them to be? I don't know really if that's the accurate way to ask that question, but I think you understand what she's saying.
Sure. I mean, and it always depends on your contacts. How healthy are your arteries? Do you have vessel inflammation? Do you have soft plaque? Do you have hard plaque? Then yes, your ApoB containing particles are more important, and you're probably going to want to lower them through some mechanism. But just looking at traditional cholesterol panel is not going to be enough. The traditional cholesterol panel, there's kind of two pieces of information to look at. If your total cholesterol is over 300 milligrams per deciliter, and your LDL cholesterol, which is calculated most times, is over 190 milligrams per deciliter, then you may have FAH, or familial hyperlipidemia, which is a genetic condition that has an effect on making more lipoproteins. The other thing that I would look at on traditional panel, I will look at it, is your triglyceride and HDL cholesterol ratio. And a lot of people want to hang their head on, they're like, well, my ratio is less than 2, and I'm not insulin resistant, so my arteries are healthy, and I don't need to worry about my cholesterol. It's just one metric of your metabolic health. You have to look at the other ones.
Right.
What are your LDL particles, your ApoB, your small LDLs, your VLDLs, your insulin, your glucose, your A1C. There's so many other metrics you got to look at. So just having one ratio that's low, meaning that you're healthy, is not true. It's a good sign, but you have to look a little bit deeper. So is your cholesterol too high or too low? It really depends on what's going on with your arteries.
Right. I kind of taken the approach personally in my own thinking that even if everything else is good, like I kind of alluded to earlier, I don't want to take the risk that I will never be exposed to inflammation or toxic particles, et cetera, that may damage my endothelial lining or, so I see these like ApoB as the common denominator, and that, if I can at least kind of lower that or keep that into a decent range, then at least I have one of the risk factors out of the way. That's not to say that I want to disregard all the other ones, because I think they're equally as important. But I think that I personally feel some people are misguided in thinking that all of the other ones are important. As long as they've got that group taken care of, that they can completely disregard the other. How do you feel about that?
It's very similar to that. I mean, again, if you want to chunk it down and make it, quote, easy for people to understand, lipids are a complex topic. But if you want to make it simple, what is your ApoB and what are your arteries doing? You have endothelial dysfunction, inflammation in your arteries, soft plaque, hard plaque. You want your ApoB lower than that. Then average, because it's a shots on goal type of philosophy. The more ApoB particles you got floating through your blood, the more chances that they're interacting with your endothelial glycocalyx and underlying endothelium. So in that case, it maybe makes sense to lower it. But what you lower it with, that's going to depend on your genetics, your goals. If you're been tried on multiple statins and have myalgias, no, don't keep challenging people with stuff that they can't tolerate. There's 9-10 other things that you can try that can modulate ApoB.
Awesome. Yeah, we think very similar about that. And the next question is actually about a medication. So please ask the efficacy of Ezetimibe monotherapy for lowering ApoB. I think I know your response to that, but
I mean, it's useful in some people, but I would typically recommend that they have a cholesterol balance test checked, and there's a couple companies that will do that. So if you're a hyperabsorber of beta-sitosterol or composterol, then ezetimibe tends to, or Zetia, which it used to be known as, would tend to work better for you. It's going to block a lot of sterol reabsorption to the portal circulation. So in those instances, they're going to see a bigger drop than maybe 20% of their lipoproteins. So does it work as monotherapy for most? Generally, no, but there's other things you can do, add on to ezetimibe that can work well for people.
Yeah, I'll usually tell people around 16% is usually what we see, lowering. And for some people that may put them into that good zone. So it's mild. But I think that maybe for those who are statin averse, maybe it's a good tool because, they could do that alongside of diet, exercise, et cetera. It'd be pretty effective. I didn't realize there was a test that you could study, that you could order to see if you're a hyperabsorber. I kind of always tell people we'll do an experiment where maybe we'll cut out, actual dietary cholesterol for a little bit and see if there's any impact. Because for the vast majority of people, I tell them dietary cholesterol isn't going to impact you, et cetera. And then we can do this test where we cut it out if we do see a drop. If saturated fat and all other variables stay, controlled for, maybe we could see. But I didn't realize there was a test. That's pretty cool.
Yeah, the Boston Heart Diagnostics does it, and there's a couple other companies that do it.
Awesome. I'm going to have to look into that. That's great. Let's see. And then this one is high cholesterol more indicative of high saturated fat consumption or high sugar. So I guess does high sugar consumption impact LDL cholesterol?
Yes, but I would say think about more kind of like a roundabout way, is that if you're eating excessive calories from any source, you're going to have issues with this. But high sugars that your body is not able to utilize instantly for energy, you're going to store it up in a triglyceride. You're going to shove that triglyceride into your fat cells, or it's going to be free floating around in your blood, or the triglycerides are going to be shuttled around in a lipoprotein. And so you're going to have to make more lipoproteins to carry this excessive triglycerides through the system. So that can drive it. And then some people, saturated fat is an issue for them. Sometimes it's the ApoE4 genotypes, but it's one of those things where there's 3,000 genes that can affect your lipoproteins. So saturated fat for some people has no effect on the lipoproteins. Other people, they switch to a keto or carnivore diet and their lipids go through the roof. Well, sometimes if they're not going to change up their diet, they could switch it to monounsaturated fat or polyunsaturated fat instead of the saturated fat, and they'll have a reduction. Or they're going to have to consider using ezetimibe if they're not going to change up their diet. So
right. So like most things, there's a lot of nuance and there's a very large, it depends. And unfortunately, it doesn't all fit into a 10-second reel of a direct black and white statement. It's very nuanced, and you could go on for hours explaining the differences there. The next one was your thoughts on statins. I think you've kind of expressed those already. So this one too, top lab markers, we discussed that. So cool, we knocked that one out of there. And then also what tests. So yeah, this one was what tests should be done to a man in their 40s. I think you talked about that. Oh, here's a funny one for you from Allie Gilbert. She wants to know if you'll be bringing the Phoenix to the Silverback Summit. Maybe with that, you can talk about what the Phoenix is.
All right, so this question is for Allie's enjoyment. So the Phoenix Pro is a device that is a shockwave device. It does not deliver electricity to the penis. It's a sound wave that helps with erectile dysfunction. So some people might have heard of GainsWave technology. GainsWave was it still is a service that's offered in some male clinics and urology offices that helps with erectile dysfunction. So they took lithotripsy technology, they decreased the frequency, so that the hertz, and the frequency of these devices basically helps do a few things. It's going to stimulate endothelial function. It's going to help release nitric oxide when these sound waves are vibrating the blood vessels. It's going to help with nerve regeneration. So it's helping the body regrow the things that have been damaged, that damage the smaller blood vessels. So the majority of blood vessels are smaller than the diameter of your hair. these blood vessels are exclusively sensitive to, smoking, high blood pressure, high blood sugar. So you're just trying to help the body basically regenerate the microcirculation. So the Phoenix Pro is kind of the home use for gains weight. And you should ideally utilize it with a pump so that you're stimulating blood flow to the penis with the pumps as well.
Where can someone get one real quick?
So there are kind of two versions of the Phoenix Pro. I think they've kind of recently changed up the business model, but there's kind of a direct to consumer version that has a lockout period so that, the treatment is like 15 minutes at home, and then it locks down for a day or two before you can turn it back on. And then there's a professional version that there's no lockout period, and the kind of frequency is a little bit higher. So you'd have to talk to your kind of healthcare provider. So it's generally a direct to either consumer or direct from your healthcare provider type of situation.
Gotcha. Okay. Well, Dr. Tyman's had to go, prevent some heart attacks. So we're going to let him go, and we're going to finish the rest of these question and answers in part 2. So you guys stay tuned for that. In the meantime, where can they find you? Just so, I know people are going to be wanting to know that.
Well, thank you again for the opportunity. I'm looking forward to come back to part 2 and answering your guys' questions. I'm available on pretty much all the social medias, but mostly on Instagram. My handle is Dr. Twyman. Monday nights, 6 p.m. Central Time. I do a topic. It's going to be mitochondrial related, circadian rhythm, heart attack, reduction techniques. And usually the first Monday of every month, I do one of these live Q&As. So if you have other questions that I haven't answered here or don't answer part 2, look at me on Instagram.
Perfect. All right. We'll put all that in the description below. Thank you so much. It was a pleasure to have you, man.
Well, thank you very much for the opportunity.